Thank you, Dr. Sabella, and a good evening to everyone. I think we'll get started right away. I'm sure you've got some plans, at least I hope you've got some plans for the evening. And let's get started right away once I figure out how to use this. Yep. All right, so we'll start with question 1. A 17-year-old female presents with a one-day history of fever, malaise, nausea. Her temperature is 39, heart rate is 134, respiratory rate 28, blood pressure is 90/56, oxygen saturation is at 98%. She is obtunded, has cool extremities, poor peripheral pulses, and the capillary refilling time is 4 seconds. She has no focus of fever. The nurse has difficulty obtaining peripheral IV access. Which of the following is the most appropriate next step? A, consult critical care to obtain central venous access. B, try cannulating the medial antecubital cephalocrate saphenous vein. C, access the radial artery. D, obtain intraosseous access. E, consult pediatric surgery to do a cut down. Excellent, that is the correct answer. And again, what you're expected to know is plan the appropriate use of intraosseous therapy. And here, access to the circulation is the most critical component of resuscitation. Again, use the largest accessible vein that doesn't require interruption of resuscitation. Don't waste time and limit your attempts. So again, the big thing was you can use intraosseous even in an older child, and all medications can be given through the intraosseous route. Question 2, 17-year-old female presents with a one-day history of fever, malaise, nausea. Her temperature is 39, heart rate 134, respiratory rate 28, blood pressure 90/56, oxygen saturation is at 98%. She is obtunded, has cool extremities, poor peripheral pulses, and a capillary refilling time is 4 seconds. She has no focus of fever. Which of the following statements is true? The patient is in shock. 20 ml per kilo of normal saline should be given over 1 hour. The patient is not in shock, but is severely dehydrated. 20 ml per kilo of normal saline should be given over 1 hour. C, the patient is in shock. 20 ml per kilo of normal saline should be given as rapidly as possible. D, the patient is not in shock, but is severely dehydrated. 20 ml per kilo of normal saline should be given as rapidly as possible. E, the patient is in shock. Dopamine should be started right away. That's excellent. It's not a good question for the end of the day, but I think you guys seem to be fresh enough. So the answer is, can you identify shock and can you treat shock? And you got it right. So in this case, you've got to remember a couple of things. The shock results from inadequate blood flow and oxygen delivery to meet tissue metabolic demands, and normal blood pressure does not preclude shock. So then how do you make the diagnosis of shock? You'd have your tachycardia, tachypnea, pallor, peripheral cyanosis, but the important part is decreased perfusion to your end organs. And which end organs are we worried about? The kidney, so look for decreased urine output. The brain, so look for altered mental status. And those are your big keys. So if you look at this diagram, what we're seeing is blood pressure depends on cardiac output and systemic vascular resistance. In cases of shock where your cardiac output is decreased, leading to decreased oxygen delivery, which doesn't meet the oxygen metabolic needs of the tissues, your systemic vascular resistance will be increased in the initial phases, and you can have a normal blood pressure. So you can have a normal blood pressure in shock in the initial stages. So what do? Again, get your access to your circulation and give isotonic fluids, crystalloids or colloids, and give it as fast as possible. And this was one of the key things. Do you give it over an hour or do you give it as quickly as possible? And the answer is if the patient's in shock, give it as quickly as possible. All right, question 3. 2-year-old unimmunized child was bitten on her hand by a stray dog while she was overseas about 10 hours prior to presentation. It was an unprovoked bite. There is a clean appearing gaping wound. Treatment should include tetanus vaccine, tetanus immunoglobulin, amoxicillin clavulinate, tetanus vaccine, tetanus immunoglobulin, amoxicillin clavulanate, rabies vaccine, and the rabies immunoglobulin. C is tetanus, rabies vaccine, and amoxicillin clavulanate. D is tetanus vaccine, immunoglobulin, the rabies vaccine, rabies immunoglobulin, the antibiotic, as well as suturing of the wound. E is tetanus vaccine, immunoglobulin, amoxicillin clavulanate, rabies vaccine, rabies immunoglobulin, and closure with tissue adhesive. All right, looks like we've got a good crowd today. All right, so most of you got the right answer. So the clues here are it's an unimmunized child, it's a stray dog, the timeline is important and it's 10 hours, it's an unprovoked bite. So these are the key things. When you're looking at the question, just look for something as why did they mention these and are there any clues to help you with the answer. So if you look at the management of animal bites, it talks about irrigation and cleansing of the wound. Primary closure of the wound is low risk, and again, they do not recommend tissue adhesives at all. Prophylactic antibiotics for high-risk wounds and those with immune deficiency. You may get a question as to what organism is common. So it's Pasteurella and Staph aureus with dog and cat bites, and Eikenella with human bites. And again, consider rabies and tetanus prophylaxis. So in which cases, when you talk about, we talked about low risk, but which are the high-risk bites? And these are moderate to severe bites, especially if edema or crush injury is present. Puncture wounds, deep or surgically closed facial bites, hand and foot bites, gentle area bites, wounds in immunocompromised asplenic patients, wounds with signs of infection, and cat bites. So these are all high risk that require antibiotics. So what about tetanus? When do you give the immunoglobulin and when do you give the vaccine? And in this case, when you look at it, for our patients, the patient is unimmunized. More than that, although it was a clean and minor wound, so you can say, well, ours is a clean and minor wound, but if you look at the exceptions, ours is an animal bite, and that's been contaminated with saliva. So that automatically puts you at all other wounds, and this is where you'd use your immunoglobulin. Then coming down to rabies, what about the rabies prophylaxis? So here we said it was unprovoked. It was from although it was a dog bite, it was unprovoked, and it's from another country. It's not within the United States where we have a low risk of rabies in at least a dog population. So in this case, we'd go with both the immunoglobulin as well as the vaccine. All right, changing gears a little bit. 15-year-old girl with muscular dystrophy is undergoing scoliosis repair. Soon after induction of general anesthesia, the end tidal CO2 suddenly rises. Her temperature is elevated and arterial blood gas shows respiratory and metabolic acidosis. What is the treatment of choice? Naloxone, flumazenil, dantrolene, vecuronium, hemodialysis. Excellent. Because this was a tough question. I'm glad to see that most of you got it right. Again, here the clue is malignant hyperthermia. They want you to know the conditions associated with malignant hyperthermia. In this case, she had muscular dystrophy, but some of the other conditions associated are myopathies, muscular dystrophy, scoliosis is an isolated syndrome as well. It's autosomal dominant inheritance, precipitated by general anesthesia. That was a clue in our patient. And again, it's characterized by sudden extreme fever, muscle rigidity, metabolic and respiratory acidosis. And the first sign, especially if they're under anesthesia, is going to be a rise in your end tidal CO2. The treatment is symptomatic as well as dantrolene. And in this case, if you even go back to the clues and you say, well, I don't know what the answer is, and I don't know what dantrolene is, you can do it by elimination. If you look at naloxone, it's an opioid antagonist. She had general anesthesia. Is it truly going to reverse anything or do anything? Probably not. Flumazenil helps with your benzodiazepines, and it's a benzodiazepine antagonist. Again, no mention of benzodiazepines. Vecuronium, yes, true, it's going to paralyze you, but in this case, I'm not sure she's under general anesthesia. Do you truly need a paralyzing agent? I don't know. And hemodialysis is good, but it's not an antidote. So even if you didn't know the answer, by elimination, I'd pick dantrolene. Question 4, 5-year-old child is brought to the emergency department after being struck by a car while crossing the street. He had a brief loss of consciousness at the scene. In the emergency department, he's alert and interactive and complains of a headache. While waiting for a CT scan of the brain, he becomes unresponsive, has irregular respirations and unequal pupils. Left pupil is 6 millimeters and non-reactive to light, and the right pupil is 2 millimeters. What do you expect the CT scan of the brain to show? Transitorial herniation, transcalvarial herniation, cerebellotonsillar herniation, diffuse axonal injury, obstructive hydrocephalus. Okay. So what they're looking for, the correct answer is A, transtentorial herniation. And we'll go down a little bit about the herniations. But I think if you go back to the question, you say what exactly is happening. So what this child does have is a lucid interval. So he had a brief loss of consciousness at the scene, then he's awake and interactive in the CT when he's in the emergency department, and then he becomes unresponsive. So he does have that lucid interval. Typically, you see the lucid interval with an epidural hematoma. And that's something, again, that you're expected to know. You might be asked that. So the lucid interval is just an epidural hematoma. The questions you've been asked, none of the answers are epidural hematoma, but what you've asked indirectly is herniation. So they did expect you to know what herniation was, and herniations represent a shift of the brain through or across regions to another site because of mass effect. So if you look at the different types of herniation, this is the epidural hematoma, which is the biconvex lens-like density that you're seeing. So what it's doing is pushing this part of the cerebrum across. So it goes across the forks here, and that's your subfalcine herniation. This is your uncal herniation. Transtentorial is down, compressing on the midbrain. And so it goes through your tentorium cerebelli here, and your cerebellotonsillar herniation would be something in the posterior fossa that's pushing down and causing a cerebellotonsillar herniation. So in this case, it's up here. So initially it would cause transtentorial. Subfalcine and uncal would be possibilities as well, but those weren't options. Transcalvarial is when you have a defect in the skull and your brain kind of pushes out through it. All right, moving on to the next one. Which of the following is an essential component in the determination of death by neurologic criteria? Reversible or irreversible cause of coma, absence of brainstem reflexes, absence of respiratory effort in response to an adequate stimulus, usually PCO2 greater than or equal to 40, a valid EEG, nuclear medicine cerebral flow scan. Okay, so this is a little tricky. So if you look at it, death by neurologic criteria is also called brain death, and the answer is B. It's a little trick into this. So if you look at it, A is reversible or irreversible cause of coma. It has to be an irreversible cause, so that takes it out. Do you need absence of brainstem reflexes? Yes, absence of cortical as well as brainstem reflexes. And if you go to the absence of respiratory effort, yes, you do need a positive apnea test. But here the trick is it's not, the stimulus shouldn't be a PCO2 of 40, because that's your normal. If you look at the PCO2, it's 35 to 45. What you're trying to prove is that despite an adequate stimulus, brainstem has no respiratory effort. It does not trigger a respiratory effort. So the patient is apneic despite an adequate stimulus. So adequate stimulus is not PCO2 40, because some of us won't breathe at 40. Maybe you're a COPD or you have sleep apnea, you normally live at 50. So at 40, you don't have the stimulus to breathe. That's why they say the stimulus should be higher. So in this case, it's not 40. What they want is 60. So again, brain death is a clinical diagnosis. You don't have to have any confirmation with a blood flow scan or an EEG. You can do them, but it's not essential. Again, it has to be an irreversible cause of coma. You've got to make sure that you've corrected any hypertension, hypothermia, or metabolic causes, and you've made sure that there are no medications that can interfere with your exam because it's a clinical diagnosis. And you need 2 exams that are performed and separated by an observation period. Again, apnea testing, as we mentioned, requires the documentation of PCO2 of 20 millimeters above your baseline and above 60. Again, ancillary studies can be used if the clinical exam cannot be performed safely, there's uncertainty of the results, medication effect is present, or to reduce the observation period, not essential. So the only thing that's essential here is absence of brainstem reflexes. All right, moving on. 6-month-old presents with a 2-day history of diarrhea, vomiting, and decreased urine output. She appears severely dehydrated. Her lab studies are as follows: sodium of 134, potassium of 5, chloride of 100, CO2 of 14, PUN of 44, creatinine of 1.6, urine sodium of 16, urine creatinine of 100. What is the most likely diagnosis? Pre-renal azotemia, renal azotemia, post-renal azotemia, SIADH, or adrenal insufficiency. Yep, most of you got it right. And again, going to what are your clues, it's pretty straightforward. The child's got diarrhea, vomiting, the child is dehydrated. You're looking at GBU and creatinine, they're elevated. She has azotemia. There's no reason to have a post-renal azotemia. So then you've got to say, well, what about pre-renal or renal? And your clues in your urine sodium. So in pre-renal azotemia, urine sodium is less than 20. The body's trying to hold on to sodium, thereby trying to hold on to water. In post-renal azotemia, it doesn't fit clinically. SIADH, the child would be euvolemic. In this case, the patient is severely dehydrated. In adrenal insufficiency, your urine sodium, again, is not low. Question 7. Previously healthy 10-month-old presents with a 5-day history of low-grade fever, poor oral intake, and a 2-day history of vomiting and fussiness. His parents state that his sleep rhythm has changed and he's awake at night and sleeps during the day. On examination, his vital signs are normal except for an elevated respiratory rate. His sclera is icteric. Heart sounds are normal. His respirations are deep but unlabored. His lungs are clear to auscultation. His liver is palpable 2 centimeters below the subcostal margin. He is drowsy, has good tone, moves all extremities. Lab studies reveal a blood glucose of 45, ALT of 112, total bilirubin of 8, and an INR of 3. Which of the following is the most appropriate after the patient has been stabilized? Outpatient management, observation for 23 hours, admission to the regular nursing floor of the local hospital, admission to the ICU of the local hospital, transfer to a hospital that performs liver transplantation. Okay, this one's interesting, but yeah, most of you got the answer correct. So what are we dealing with? And here are your clues. It's a short history, just 5 days. Important is that the sleep rhythm's changed. Has an elevated respiratory rate, deep respirations, unlabored with clear lungs. So it's probably not a pulmonary etiology. Patient's drowsy. Blood glucose is low, ALT is high, and Billy is elevated, INR is 3. So what you're dealing with is acute liver failure. So acute liver failure is a clinical syndrome resulting from acid necrosis or severe functional impairment of hepatocytes. Definition includes a biochemical acute liver injury. So again, the time period is important. No chronic liver disease and hepatic coagulopathy. If your INR is greater than 1.5 and not corrected with vitamin K, there should be clinical hepatic encephalopathy, or it could be INR greater than 2, regardless of the encephalopathy. Again, how do they present? You can have progressive jaundice, fetor hepaticus, fever, anorexia, and vomiting and abdominal pain. If you have a rapid decrease in liver size without clinical improvement, it's an ominous sign. Hepatic encephalopathy presents initially as sleep disturbances, which is what our patient had. Infants may have irritability, poor feeding. Older children may have asterixis or your flapping tremor. Later on, they become somnolent, confused, combative unresponsiveness. Respirations increase later. Later on, they have respiratory failure. So they have respiratory alkalosis initially. Treatment is again focused on prevention management of complications, but there should be an early consideration for liver transplant. And again, who makes the decision, is my patient a candidate for liver transplant or not? It ideally should be done at a center that does liver transplants. So if you're sitting in an ED, should you admit to your hospital or should you send to another hospital? And this is where the correct answer is send to a place that does liver transplantation. So once stabilized, send to that, and they can make a decision whether the patient needs it or not. A 15-year-old female presents with a 6-month history of fatigue, malaise, anorexia, and vomiting. She has lost weight. On examination, she has orthostatic hypotension and generalized hyperpigmentation. Lab studies reveal a serum sodium of 128, potassium of 5, chloride of 98, bicarb of 18, BUN of 24, and blood glucose of 54. What is the most likely diagnosis? SIADH, chronic diuretic use, adrenal insufficiency, chronic renal failure, eating disorder. Excellent, I'm impressed. All right, so what are we saying? Cortisol deficiency causes a decrease in cardiac output and vascular tone, leading to orthostatic hypotension. Aldosterone deficiency causes decreased sodium reabsorption, the distal nephron, leading to hypovolemia, hyponatremia, hyperkalemia. Cortisol deficiency also leads to a decrease in the negative feedback to the hypothalamus and pituitary. So you have an increase in ACTH, another peptide secretion that's responsible for the hyperpigmentation. So our patient showed all this. If you want to rule it out, SIADH would be euvolemic. If you have chronic use of diuretics, the patient would be hypokalemic and have metabolic alkalosis. Eating disorders, again, bulimics purged by vomiting, and there's also abuse of laxative diuretics, and they usually have hypokalemia, not hyper. Okay, what size endotracheal tube would you use to tracheally intubate a 4-year-old child? 5 millimeter uncuffed tube, 4.5 millimeter uncuffed, 5 millimeter uncuffed, 5 millimeter cuffed, 5.5 millimeter cuffed. All right, that's interesting. So this is one of those where, unfortunately, you just have to memorize it. I'm not sure how else you can remember. So if you can't memorize it, I just do eeny, meeny, miny, moe, something like that. So the answer is 5 millimeter uncuffed, which again, 44% or most of you got right. But so what's your size? In term babies, you'd use 3.5 millimeter uncuffed. And whenever you're looking at a cuff tube, it's always one size smaller or 0.5 millimeter smaller. So in this case, it would be 3 millimeter cuffed. Infants, it's 4 millimeter uncuffed to 3.5 cuffed. For greater than 2 years of age, and this is the only formula you need to remember, is uncuffed is age by 4 plus 4. So if you know this, then you don't need to remember anything else. You just go one size smaller or 0.5 millimeter smaller, and you'd get your cuff tube. And if you're doing it practically, it's the size of your little finger if you can't remember it and you're stuck. If they ask for the depth of insertion, just remember the previous formula, age by 4 plus 4, and then multiply by 3, and that's the depth that you do it. So just going back to our patient, it's a 4-year-old. So 4 divided by 4 is 1, plus 4, that's 5. So it's a 5 millimeter uncuffed tube. And there's an option of 4.5 cuffed. You could put that, but there isn't that option. All right, you're called to evaluate a 4-month-old infant with bronchiolitis who's intubated and ventilated and has worsening hypoxia. You notice that he's in respiratory distress, his neck is flexed, he has copious oral secretions, and very poor air exchange of the left lung with good air exchange on the right. There is dullness to percussion on the left hemithorax. What is the most likely reason for hypoxia? Right lung pneumothorax, right lung atelectasis, left lung pneumothorax, left lung atelectasis, or esophageal intubation. All right, this one you had to think, but again, most of you got it right. So what are your clues? So what they want you to know is potential complications associated with endotracheal intubation. So all those complications are possible. You've just got to pick up which one of them does this patient have. And here are your clues. They mentioned copious oral secretions, and there's a reason why it was put in. Poor exchange over the left lung, so you know the pathology is on the left. So now you've got to decide, is this going to be pneumothorax or atelectasis? Could this be esophageal intubation? And again, the other clue is this dullness to percussion on the left side. So if you go down to our clues, one thing is look at the complications. Immediate complications could be hypoxia, hypotension, bradycardia, arrhythmias, laryngospasm, cardiac arrest, aspiration, esophageal intubation, dental injury, pharyngeal laceration. Late ones are subglottic stenosis, vocal cord paralysis, laryngotracheal injuries. And at any time, you can have dislodgement. That could be accidental extubation or esophageal intubation, main stem intubation, and others could be air leaks, atelectasis, infections, blockage of endotracheal tubes, and of course, you can have a pneumothorax at any time. So the question is, you've got to decide which one of these did the patient have. And I think here are your clues. When you're looking at this patient, you said copious oral secretions, which tells you that there's a chance that the tube may be dislodged. It's telling you you have a tape or you have something, but because of the secretions, it's likely to get loose. Poor exchange of the left, so it's telling you that your left has a problem. So you've got to decide, is it left side atelectasis or pneumothorax? You have dullness to percussion on the left, which makes you think it's more likely to be atelectasis. You'd have resonance if you had a pneumothorax. The other part is the neck is flexed. So whenever it tells you the neck is flexed, what it's trying to tell you is when you flex the neck, the tube tends to go deeper. So if it's deeper, more likely that it's going into one of the main stem bronchi. And the right is usually straight, so it's more likely to go into the right, but doesn't always have to be. So in this case, it's probably gone down to the left, and that's why you have it's gone down to the right, and that's why you have collapse of the left lung and left lung atelectasis. And those are your clues to it. Little thinking, but shouldn't take you that long now that you've gone through it once. All right, we're past the halfway mark. Patient with septic shock who's intubated and mechanically ventilated develops worsening oxygenation 2 days later. This is a chest x-ray. The most appropriate next step is administration of furosemide, increase PEEP, increased respiratory rate, start methylprednisolone, increase inspiratory time. All right, I'm glad. So the answer is B, increase in PEEP. And here's your thing. If you see PEEP on the answer as an option, blindly click it. Intensivists love PEEP. The answer to everything is PEEP. So do that. But a little more on a serious note, what does this patient have? This patient most likely has ARDS, and treatment to ARDS, in other words, is non-cardiogenic pulmonary edema. So what do? You do PEEP. Does furosemide truly help? No. The rest of it, maybe, but truly the answer is PEEP. So we're going to move on to the next question. The patient with septic shock and ARDS develops hypotension with worsening oxygenation. And this is the chest x-ray now. What complication of ARDS does the chest x-ray show? Bilateral atelectasis, subcutaneous emphysema, pericardial tamponade, pneumothorax, pleural effusion. So I'm going to go back one more time. Okay, that's great. Most of you picked up the right answer, and that is subcutaneous emphysema. So here's what we're showing. So what you do see is lots of subcutaneous emphysema. All this air shouldn't be there in the subcutaneous tissues, all this black. What you're also seeing is chest tubes. So you're seeing these pigtail catheters. So the patient did have a pneumothorax at some point in time, but right now you don't see a pneumo. All you're seeing is all this air in the subcutaneous tissue. So what do they want to know? They want you to know about ARDS, and again, complications of mechanical ventilation. So we have this, what is ARDS? Again, this is the revised definition. So it says it should be acute, so 1 week of a known clinical insult or new or worsening respiratory symptoms. Chest imaging shows bilateral opacity, is not explained by fusions, atelectasis or nodules. The origin of the edema should be respiratory failure, not explained by cardiac failure. So it's a non-cardiogenic edema. And you need an objective assessment to exclude hydrostatic edema. And there should be a problem with oxygenation. And again, it's been classified as mild, moderate, or severe. They want you to know a little more about the etiology, and here it could be direct lung injury or indirect lung injury. Direct would be pneumonia, aspirations, contusions, near drowning. Indirect could be something like sepsis, trauma, blood transfusions, pancreatitis, drug overdose. What do? Use PEEP. How does PEEP help? Improves your functional residual capacity, improves lung compliance, decreases intrapulmonary shunting, and essentially it increases oxygenation and allows you to lower your FiO2. It also helps decrease your LV afterload. So can it be used for cardiogenic edema? Sure. Again, judicious use. Now, moving gears, the outcome of a child with submersion injury is primarily determined by which one of the following factors: the effectiveness of resuscitation efforts at the scene, freshwater versus saltwater drowning, wet versus dry drowning, volume of aspirated fluid, and initial ECG rhythm. Excellent. So it is the effectiveness of the resuscitation efforts at the scene. And moving on to the next question. 2-year-old child rescued following a submersion injury and who required CPR in the emergency department is admitted to the ICU. He is intubated, mechanically ventilated, and requires sedation. About 72 hours following admission, his sedation requirements are minimal. His heart rate has trended down from the 130s to the 70s, and his blood pressure has increased to 130 systolic. His pupils are equal and reactive to light. He moves all extremities to pain. What is the most likely explanation for the change in neurologic status? Development of cerebral edema, spinal cord injury, epidural hematoma, oversedation, development of CNS infection. All right, again, most of you got it right, and the answer is development of cerebral edema. So this is a patient with a submersion injury who required CPR in the emergency department. So he did have a period of asphyxia. This is 72 hours later, 3 days later. He doesn't require any sedation. His heart rate has gone down, so he's got bradycardia, blood pressure has gone up, so now he's hypertensive. So this is what are we talking about? He got 2 of the 3 present for a Cushing's triad. We have a history of asphyxia, so it kind of points out to this is the time that you'd have your cerebral edema developing and kind of peaking up. We talked about submersion injury, and the outcome is related to the extent of cerebral injury. And again, this depends on the severity and duration of hypoxia. So prognosis depends on neurologic status after resuscitation. Additional injury may result from arrhythmias, ongoing pulmonary injury, reperfusion injury, multi-organ dysfunction. And again, it's the hypoxic ischemic insult that leads to the cerebral edema. So you can have a poor prognosis if the event is unwitnessed. You have a prolonged time to resuscitation. There's a need for CPR at the scene, which continues on into the emergency department. There's prolonged coma, longer submersion times, higher lactic acid, blood glucose, lowered Glasgow Coma score, apnea, bradycardia, pupillary reactivity at the time of admission. 5-month-old infant presents with a 2-week history of difficulty in feeding and diaphoresis. He has failed to gain weight. On examination, his temperature is 37, heart rate is 180, respiratory rate is 56, blood pressure is 88/50, oxygen saturation is 92%. He's lethargic, has cool hands and feet, heart sounds are normal, there is no murmur. He has bilateral crackles over his lung bases. The liver is palpable 4 centimeters below the subcostal margin with a span of 8 centimeters. What is the most likely diagnosis? Heart failure, sepsis, bronchiolitis, congenital adrenal hyperplasia, nephrotic syndrome. Wonderful. 4-day-old infant is brought with a history of feeding difficulty and difficulty in breathing. That started about 12 hours earlier. On examination, her temperature is 35.8, heart rate is 170, respiratory rate is 62, blood pressure is 72/48, oxygen saturations are 78%. She appears pale and gray, has cold extremities, poor pulses, and is in respiratory distress. She moans but does not withdraw when IV access is obtained. 5 ml of urine is obtained on catheterization. She has no murmur, extensive crackles and wheeze, and hepatomegaly. What is the most essential next step? Digoxin, milrinone, epinephrine, prostaglandin E1, dobutamine. All right, we need 100% on this one. All right, close enough. So the answer is prostaglandin E1. And what they want you to know is recognize findings associated with cardiogenic shock in children of various ages and plan appropriate management for these patients. So going to the first page, you look at heart failure in infants, can mimic bronchiolitis, except now look for the liver. And the liver span's important because in bronchiolitis you can have the liver being pushed down, so the span's important, and that was a clue. So depending on the cardiac reserve, manifestations of heart failure may occur at rest or activity. In infants, this activity is typically feeding, so they can have feeding difficulty, poor weight gain, tachypnea, excessive perspiration, irritability, or labored respiration. Wheezing can be more prominent than rales and can be confused with bronchiolitis, and that's important as well. You can have hepatomegaly, cardiomegaly, tachycardia, gallop rhythm. Again, JVD is not commonly seen in infants because of their short neck, and edema is again less often seen on legs and feet. So if you have someone who comes in the first month of life, and especially within the first week, think of ductal-dependent lesions. So you're thinking of congenital heart defects with ductal-dependent lesions. Your doctor tends to close about 15 hours on an average. So you have someone at 4 days, 3 days, within 7 days. If you see prostaglandin E1 on that, just hit it. Anyone less than 7 days, you look at it and say it's in shock, and you have that as an option, just hit it, you won't be wrong. Can you give milrinone and dobutamine and dopamine and epi and norepi? Sure, you can do all that, but most essential is your prostaglandin. So even if you have the others, you're tempted to say, well, I like the epi, he needs epi. Yeah, sure, he needs epi, but what's going to be life-saving is the prostaglandin. So pick the prostaglandin. A 14-year-old girl with lupus presents with sharp chest pain that increases on inspiration and is relieved by sitting upright or prone. She's afebrile with a heart rate of 124, respiratory rate of 26, blood pressure of 90/78, and has oxygen saturations of 96%. She has distended neck veins. ECG shows nonspecific abnormalities of the CT segments and low voltage QRS amplitude. What is the most likely diagnosis? Pleural effusion, pericardial effusion, pneumothorax, pulmonary embolism, myocardial infarction. Yep, most of you got it right. So we look at it here, there are clues. So you have a patient with lupus, so they are prone to develop pleural effusions, pericardial effusions, PEs, DVTs, maybe an MI. So it comes down to chest pain. And again, typically this one says it's relieved by sitting upright or prone, very suggestive pericardial effusion. If you look at the blood pressure, 90/78, so very narrow pulse pressure. Distended neck veins, that tells you that she has JVD. And the EKG is non-specific, but they've said that, they've mentioned an EKG. So again, all these, when you look at the low pulse pressure, distended neck veins, chest pain, all that points to maybe a cardiac tamponade. So if you look at cardiac tamponade, it's life-threatening, could be slow or rapid compression of the heart due to accumulation of fluid, pus, blood, clots, or gas within the pericardial space. Again, the primary abnormality is compression of the cardiac chambers as a result of the increasing pericardial pressure. And as the chambers become progressively smaller, the myocardial diastolic compliance is reduced, cardiac inflow is reduced, therefore cardiac output is reduced. So you get the tachypnea, tachycardia, typically narrow pulse pressure, JVD, pulsus paradoxus. You can hear the pericardial rub maybe, distant heart sounds. Hypotension, cool hands and feet. EKG is non-specific. The classic X-ray sign is your Erlenmeyer flask deformity. And the echo for a tamponade is pretty sensitive and shows compression and collapse initially of the right atrium, and then maybe you may see the right ventricle as well being compressed. All right, winding down. 6-year-old child was an unrestrained backseat passenger in the car that was involved in a head-on collision with another car. He is tachycardic, tachypnic, hypoxic, has paradoxical chest wall movement with inward movement on inspiration. Trachea is midline, there's decreased air exchange on the right side. Chest X-ray shows multiple bilateral rib fractures and airspace opacity on the right. Which of the following is most appropriate? Tracheal intubation and administration of PEEP, insertion of large bore thoracostomy tube, needle aspiration followed by placement of thoracostomy tube, tracheal intubation followed by a thoracotomy, tracheal intubation and strapping of the chest. I guess no one was listening. You saw PEEP, hit PEEP, always hit PEEP. So on a more serious note, what they're talking about is, I think if you look at it, he was a patient in MVA. The big clue is your paradoxical respiration. So normally when you take a deep breath, your chest wall moves out. What they're telling you is that there's inward movement of inspiration. So that's your clue. And that's the biggest clue that you have. Then to kind of confirm it, it says there's multiple bilateral rib fractures. And the rest of it is just adding to your confusion. So they're trying to tell you is he has a flail chest. So again, flail chest, you have fracture of 2 or more ribs in 2 or more places. And the paradoxical wall motion is, it moves inwards with inspiration, pushes outward during exhalation. And this is what it does. You take a deep breath, instead of being pulled, the ribs are broken, so it's no longer stabilizing the chest. So as you take a deep breath, it gets pulled in. With that negative pressure, negative pull pressure, it gets pulled in. When you exhale, it kind of goes out. So that's your flail chest. So how do you treat it? So in the olden days, they talked about strapping the chest. No one straps the chest any longer. So what do? They say, if you go back to our patient, he was hypoxic. So they said he is hypoxic. So that's your big clue. So you're looking at it, and then he's got this opacity. So what is this opacity? Most likely it's a contusion. So again, do you treat a contusion with a tube? No, you don't. There's no mention of a hemothorax or a pneumothorax. Could it occur? It could occur. So what do? The problem with the flail chest is not so much, you could be tachypnic, you have this paradoxical movement, which is kind of a little annoying to watch. But truly, do they have a problem? The problem arises from the associated injuries, and most of them do have associated injuries, which could be contusions or hemopneumothorax that may require treatment. But for the contusion, all you do is wait it out and support. So what you do is, how do you support it? You just, in this case, intubate, give some PEEP for the hypoxia, and the PEEP also helps this, because it's positive pressure, it'll stabilize the chest. What do? Do you keep them intubated till the ribs heal? No. As long as your saturations are okay, your contusion and whatever the associated injuries have healed, then you can extubate. Old days, they said stabilize by strapping. That's gone out. Okay, 6-month-old was brought in by his mother who noticed abnormal jerking movements of his extremities associated with eye deviation. Following a dose of lorazepam, the movement stopped. On examination, you see bruising and boginess behind his right ear. The tympanic membrane is intact but appears purplish. The anterior fontanelle is tense. He has some older new bruises over his body. Examination of the cardiovascular, respiratory system, the abdomen, genitourinary system, muscular system is unremarkable. You request a CT scan of the brain. What other examination should you consider? Retinal examination, audiometry, coagulation profile, drug screen, testing for osteogenesis imperfecta. Excellent. So what they're showing is a bruising and bogginess behind his right ear, intact tympanic membrane, but that appears purplish, and the anterior fontanelle that's tense. So again, children are prone to basilar skull fractures. Temporal bone fractures manifest as the battle sign or post-auricular ecchymosis, hemotympanum. They could be hearing loss, facial paralysis, CSF autoria, or rhinorrhea. And this is things that you need to recognize. Again, you've got to know about abusive head trauma, and I think most of you, since 95% of you got it right, I'm going to skip. Looks like you know when to recognize abusive head trauma. If you do suspect it, go ahead and look for retinal hemorrhages. So this is our second to last question. Teenager is brought by EMS following a motor vehicle accident. He was intubated at the scene for anxiety and respiratory distress. His temperature is 36, respiratory rate is 16, and he is being bagged. Heart rate is 55, blood pressure is 80/36, oxygen saturations are 99%. He is alert but unable to move his extremities that are flaccid and areflexic. He has bruises over his face, chest, and back. There is no evidence of bleeding externally, no obvious deformity, abdomen is non-distended. The blood pressure does not improve with crystalloids. CT brain, C-spine, chest, and abdomen are unremarkable. What is the most appropriate next step? Administration of colloids, transfusion of back cells, back to RBCs, starting norepinephrine, starting dobutamine, arranging for pericardiocentesis. Okay, again, most of you got it right, so let's look at the case again. What they're talking about is this patient has spinal cord injury, and what are your clues here? So one is that he's unable to move his extremities that are flaccid and areflexic. So that's automatically telling you that he has a spinal cord injury. I think the other part that you look at is, look at this. He's hypotensive, but his heart rate's down. He's a trauma patient. Most of them, you say, well, you come in with following a traumatic injury, you'd expect your heart rate to be up. His heart rate is down, and is that providing you a clue? And that is, so you have a patient who's come in, you're suspecting spinal cord injury, your heart rate is low, with low blood pressure, that confirms your spinal cord injury. Well, they talked about a CT scan of the spine being normal. Can you have a normal CT of the spine? And the answer is yes. And that's the term SIVORA. So in children as compared to adults, children with spinal cord injury, it's more likely to occur as a result of birth injury. They're more likely to have SIVORA, and more likely than adults to have atlantoaxial subluxation. So what is SIVORA? It's spinal cord injury without radiological abnormality. So there's absence of any radiographically evident fracture, dislocation, or malalignment, but you do have neurological signs and symptoms referable to the spinal cord after a traumatic event. The MRI spans the spectrum from normal to complete cord disruption, along with ligamentous and disc injury. So what exactly happens? So think of it as, you have the vertebra and they're just moving back and forth. So it goes forward, gets displaced, comes back. So there is no fracture. So you may or may not see this ligamentous injury on MRI. It can be absolutely normal, but you will have all these signs of spinal cord injury, and that is SIVORA. Next part is shock. So you have spinal shock with this flaccidity, no spontaneous motion, no deep tendon reflexes. And does this patient have neurogenic shock? It's kind of distributive shock. And in this case, the spinal cord injury disrupts the sympathetic outflow, so it results in unopposed vagal tone. Because there's no sympathetic outflow and there is parasympathetic flow, you have hypotension, bradycardia, along with the neurologic dysfunction and warm, dry skin. So the diagnosis should be one of exclusions. You treat with fluids, but again, if your hypotension is refractory to it, then you require either phenylephrine or norepinephrine, a vasopressor, some sort of a alpha agonist. Our last question. 10-year-old child is rescued from a house fire. He's alert but confused. His voice is hoarse. Blackish nasal discharge is seen when he blows his nose. Oxygen saturations are 90% in room air. Second-degree burns are noted over his face, torso, and upper extremities, totaling 20% body surface area. Which of the following is indicated? Corticosteroids, broad-spectrum antibiotics, endotracheal intubation, restricting fluids, avoidance of supplemental oxygen, and aggressive airway toilet. Excellent. So what are we dealing with? We're talking about inhalational injury. So when you look at our patients, it says house fire. And then you have the blackish nasal discharge when he blows his nose. So you have some soot coming out from his nose. He's hypoxic, and you do have burns over the face. So you have inhalational injury. How do you treat inhalational injury or inhalational burns? Again, that occurs from aspiration of toxic products of combustion. You can have pulmonary insult associated that can have direct lung injury or systemic consequences. You treat with intubation. What you want to do is you want to secure the airway before the swelling gets too bad. You have airway swelling. You don't want the airway swelling to get too bad to the point where now you have trouble intubating the patient. So you secure the airway, and that's your biggest clue. Do steroids help? No. Does furosemide or diuretics help? No. Does restricting fluids help? Nothing helps. All you've got to do is secure the airway, support oxygenation. How do you suspect inhalational injury? The burns occur in an enclosed space. There may be stridor, hoarseness, or cough. There are burns to the face. There's soot in the sputum, nose, or mouth. There may be a decreased level of consciousness, and this could be from your carbon monoxide poisoning or something. And again, there may be hypoxia or increased carbon monoxide level. So management is control of the airway. Again, give 100% oxygen until you've made sure that he doesn't have carbon monoxide toxicity. There's no role for corticosteroids, antibiotics, or Lasix. Thank you very much, and good luck to all of you.